So what I'm going to do over the next 35 minutes or so is talk about non-invasive assessment of graft after liver transplant. So just to start with our own data of more than 1,000 transplants, we've done about 930 live donor liver transplant, about 75 cadaveric transplant, and nearly 140 pediatric transplants. So we do about 110 transplants a year. And we do equally good number of pediatric as well. That's about 10% of activity, which will be in any good center as well. And then coming to the outcome, so this is the post-transplant survival. This is as good as it can get, and in any good center in the world actually. Maybe we might have done better than others because of the sickness of the patients, and I'll come to that part of the story later on or by the end of the talk. So in CLD, we have a 1 month survival of 93%, which goes on to about 80% at 5 years. In ALF, obviously, because of the sickness of the patient, the 1 month survival is 83% and goes up to 65% at 5 years. And ACLF, it is about 78% at 1 month, and it is 5-year survival is about 70%. So it's just a reflection of the sickness of the patient at the time of the transplant. And this is reflected by the MELD score as well. So if we take our median MELD, it is about 24. So if we compare with the world literature in terms of doing predominantly live donor liver transplantation, the median MELD will be around 15 to 16. And obviously, I think we all have now matured enough to know that MELD is a bad predictor of post-transplant survival, because lots of things like sarcopenia, hepatic encephalopathy, refractory ascites, and ascites-related complications actually don't get reflected in MELD score as well. So what's the journey of a liver transplant patient? So it's about pre-transplant status, which plays a very important part, because how sick your patient is at the time of transplant and how well it is optimized, that will get reflected in whatever is going to happen intraoperatively and post-operative as well. So all this has got an interrelated relationship in terms of overall outcome of transplant patient. So why liver transplant is considered to be most complex operation or most complex patients to be managed both pre, intra and post-operatively? Because if you take other transplants, I'm not saying that others are easier, but why this is more complex than anything else. And that's because a liver patient actually has underlying physiological disorders in almost every organ at the time of transplant. So they will have cerebral part, they will have renal part, they will have cardiovascular part, they will have lots of metabolic dysfunction as well, and obviously clotting and all is disturbed as well. So this all get reflected what is going to happen to them in peri-transplant course as well, and that's where the outcomes are reflected as well. And that's why liver transplant is considered among all the transplant to be one of the most complex operation and most complex perioperative management as well. So, if we take graft dysfunction and then we talk about the causes of graft dysfunction, then there are lots of factors actually which comes into play, which will be donor factors, recipient factors, ischemia reperfusion injury, and then obviously vascular problems, biliary causes, rejection, de novo infections, recurrence of the disease. So there are too many players here in terms of assessing graft functions after transplantation. And it's not, the problem is not about just too many players coming into play in one particular patient, but the problem is overlapping of clinical and diagnostic tests results in difficult decision making in perioperative course in this group of patients. So it's very important to need to know the background of a particular patient, an index patient, where he's coming from, what are the factors which are playing part. So the whole story starts from donor factors, which especially in cadavers like age, cause of death, graft quality in terms of statosis, steatohepatitis, ICU stay. If they have prolonged ICU stay before donation, then again it plays an important part. Whether they were on inotropic support, whether they require a CPR, which happens in many patients actually. So if there was a downtime, this can all reflect into ischemic insult on the liver as well. And obviously whether they had sepsis And then the logistic issue about how much was the cold ischemia time in terms of liver traveling to the center, how quickly we got in the liver, and how quickly we could transplant. Then recipient status is very important. So whether in terms of their MELD score or PELD score, and obviously ALF and ACLF are sicker ones, they need a lot of care, and that get reflected in their perioperative outcome because they do have some sort of multi-organ failure or dysfunction at the time of transplantation. And preoperative infections, which is very common in Indian patient because most patients actually decide to have a transplant only after once they had multiple hospital admission. And what multiple hospital admission here mean is they will have some sort of multi-drug resistant bacteria going on as well. Again, this is in particular common to Indian patients, sarcopenia and refractory ascites. So if we look at grossly, when an Indian patient make a decision, it's about recurrent hospital admission and complications of ascites. That's where actually that's my observation, that once the ascites become unmanageable by all the medical treatment, then only and most Indian patient will decide that now they need to have a transplant. Again, in terms of portal vein thrombosis, which is very common, about 10-15% of patient will have, and this actually leads to complicated, more complex operation, blood loss, and that also get reflected in perioperative outcome. Then other organ dysfunction, it is, as I said, most organs will have some or other physiological disturbance before patient coming for transplant. So in terms of intraoperative, it's very important to monitor them carefully because there is a lot of physiological fluid shifts which happen because of blood loss, ascitic losses as well. So it's they require a very careful intraoperative hemodynamic assessment, and measures need to be taken at the right time in order to make sure that perfusion pressures are good so that they don't develop organ dysfunction post-operatively as well. Then you need to look into blood loss. Blood loss actually in general, we all know more blood loss, more complicated the operation, and it will reflect on the post-operative recovery as well. Warm ischemia time, so again, how long it has taken to soothe the liver in is a very important predictor of outcome. Then types of reconstruction, the more the complex the operation is, and the more likelihood of development of complication as well. So technical issues play an important part, especially in live donor liver transplantation, where you've got a partial graft, smaller vessel size, and then it has to fit in properly actually in order to make sure that you don't get a technical complication as well. And graft volume and JRW are important as well. So coming to how, whether we can predict a particular patient in terms of what their outcome is going to be. And we've done quite a bit of, I'll say, assessment in terms of how we can predict in a particular patient. This is a difficult task in live donor liver transplantation. So we try to develop a score system. This is called as EGLR score. And Nilesh and Guresh has really worked hard on how to develop this score. So what we have come up with, before coming to the score, I just want to highlight in this particular data, this is our own data. So if we see, this is about more than 600 transplants being performed over nearly 8 years or so. So DDLT were excluded, ALF were excluded, and pediatric were excluded. Then we come down to live donor liver transplant, nearly 500 of this. So just make point of this, 22 of this died just unrelated to graft function. So this is cardiac mortality, respiratory mortality, intracranial bleed, invasive mucormycosis, and primary non-function as well. Only one of that. So this is just a reflection of how this patient profile is, and in terms of their perioperative outcome as well. So it's not just about graft. There are other factors which play a more important part as well in terms of perioperative outcome. And that's where I think we need to be careful. So that's where basically timely transplant and thorough assessment before transplant in order to make sure we can minimize this as well. Then this is a vascular complication which are as good as they can get in the literature. Biliary complication, about 40 of this, but only 5 to 6% has required biliary intervention in terms of endobiliary interventions to manage them. Then, so when we come to final study population of around 400 here, so when we take early graft dysfunction rate, then about 92 of this actually developed early graft dysfunction. So that's defined by bilirubin of more than 10 and an INR of 1.6. I'll come to the details of this data at the end of the talk, why this is important to know, because we developed the definition and how it is reflected in terms of the literature which is there and how our data is different from there as well. So the point here in this chart is there are lots of other factors which play an important part in perioperative outcome rather than just graft function. So this is the score we tried to develop. That's based on, we did a multivariate analysis to look at the risk factors, and then we developed an equation in terms of what will be the probability of prediction. So this is somewhat similar as MELD score. So MELD score can predict the survival probabilities in chronic liver disease. So this is a score which can predict post-transplant outcome in a patient, which is based on donor age, graft weight, and MELD score as well. So previously, there's a lot of literature in live donor liver transplantation about JRWR and hyperperfusion injury and all those, but this is very different from that. So, and you can see the survival, the probability, this score is very good. As the score goes up, the outcome actually decreases as well. So this is the ROC chart for this, and you can see the probability there is very good in terms of prediction. It's more than 80% there as well for the derivation cohort and for the validation cohort as well. So we had an internal validation of this score, and which stands good in terms of on the validation group as well. So this is now actually available online as well, where you can put in the score here, donor age, graft weight, which we know before the operation as well, and a MELD score, and it will give a score. And based on that score, you can actually have what will be the risk of early graft loss after transplantation as well. And it has got a good probabilities as well. So in terms of coming to non-invasive assessment, so there are three things which interplace: clinical parameters, laboratory parameters, and relevant imaging. And that's where actually, in every patient there will be something different. Every patient is unique in itself, and we need to make an assessment and decision based on a particular patient as well. So assessment actually generally goes like we assess every other patient. It's more ABCDs here rather than even, I'll say, more than in trauma here. So because you need to have a look at very good at hemodynamics, mental function, renal function, respiratory function, and coagulation. And what we have got to play with is you've got a blood gas, which I think is the most important thing, because most thing will reflect in gas before anything happens to the patient. So your monitor and gas actually will reflect most of the things, what is going to happen to the patient in next 24, 48 hours rather than anything else. Then obviously in terms of liver, glucose metabolism is important, and hypoglycemia is a bad sign. CBC, I'll come to this. These are very important. You need to look at them in a dynamic way, where they are going. If there's cytopenias, they reflect sepsis. If the counts are remaining good, then you're okay. If the counts are going up, then it doesn't really necessarily mean sepsis always. It can be graft dysfunction as well. Other things comes as well. LFT, again, you need to look what are the patterns. So it is always a dynamic assessment rather than one particular test actually, where the flow of those tests is going. Then in terms of kidney function test, INR, clotting, you need to look in terms of whether the INRs are improving or they are staying up as well. Then some of these centers use inflammatory markers like CRP, ProCal. I'm not a great believers on those, because they are just inflammatory markers. They don't help you in decision making. So they can be raised in sepsis, they can be raised in rejection, they can be just raised in terms of postoperative. It happens in most postoperative patients as well. So when we look at the patient in ICU in terms of how liver is doing, how patient is doing. So it's about hemodynamics will reverse, and this is one thing which we observed consistently. Once the cirrhotic liver goes out and the new liver comes in, the hemodynamic actually changes dramatically. So what happens is you've got a hyperdynamic circulation in a cirrhotic patient. Once that liver comes out, then suddenly the blood pressure will actually shoots up. So a bradycardia and a hypertension in next 24 hours after the operation is a good sign in terms of patient going home. And then obviously improving renal function if they're making good urine, resolution of metabolic acidosis, decreasing lactate. Lactate, I think, great believer in lactate, because rising lactate is always worrying. You need to treat lactate. You can't just leave lactate like that it is rising and you keep looking at the values, because in next 24 hours there will be organ dysfunction and then it will be failure. So you need to treat them very well, and there should be no hypothermia, coagulation function improving LFTs. So most of the time, immediately after the transplant, there will be rise in AST, ALT as well, which will actually, you expect that in next 24 hours they will come down. And then once they're coming down, then the trend should always be downwards. If they're going up, then you really need to look into what is happening to the patient. So just to say how important fluid management in ICU in these patients are. So when we look at the partial graft, and I'll just tell you, so this is cava here, this is inferior vena cava, this is portal vein anastomosis here, and this is our outflow. So this is the complex of right hepatic vein and middle hepatic vein, which have been joined together and has been anastomosed onto the cava. Now, if you give a lot of fluids to this patient, then there will be overfilling into the cava, and that will get reflected onto the liver as well, and that liver will be actually then lead to congestion, and then you can get rising lactate as well. And this partial livers in this situation won't regenerate very well, and you will start thinking, we've done a good job, good anastomosis, but patient is not improving. Day one lactates are rising, and then you just, if the fluid balance are not good, if intraoperatively more fluids have been given, or postoperatively just to chase a urine output, more fluids have been given, this all will get reflected in their clinical course. And this will directly influence the portal pressure and portal flow as well. So a CVP, what we found was a cutoff around 10. If you've got a CVP of more than 10, you will have more lactates, and that will cause graft injury as well. So need to be careful how you manage in immediate postoperative period. Then simple things like platelet. So I had a lot of interest into this in terms of how platelet behaves after transplantation. And what we found was most patients, there will be a drop in platelets. Immediately after the transplant, there will be a drop, and the drop will continue for 3-4 days. And then they will go up. And this drop is basically recruitment of platelet into the liver for liver regeneration. So it's not pathological, it is basically more physiological, because the portal flow has opened up, so more platelets are being recruited into the liver in order to promote liver regeneration. Now the point is, that's a physiological process, but if the platelet don't go up after day 5 of operation, then it's worrying actually. It's directly related to what is going to happen to the patient in terms of major morbidity and early graft dysfunction as well. And it's a good predictor of sepsis as well. So all these parameters, grade 3-4 complication, mortality, early graft dysfunction, post-transplant sepsis, post-transplant cytic drainage. So if the platelet has not gone up after day 5, then it's a sign that there is something going to happen to the patient, and you need to be careful. And this simple thing actually is great in terms of decision making on ICU in immediate post-operative period, because one of the complexities of liver transplant is how to give immunosuppression and how to judge a patient. Although you can have a clinical judgment, but many a times, tachycardia may be slightly persisting, and patient are, because they are weak, they are still not up to it. And then you're wondering whether you want to give immunosuppression, not to give immunosuppression. And if you got a low platelet which is persisting, it's a good sign that sepsis might be coming. Just hold back. Don't give immunosuppression to this patient. They will, and the sepsis will get reflected in few days. So it just have to be, it's a good marker of deciding immunosuppression in immediate postoperative period. So this is just the ROC curve in terms of platelet of low, less than 30 versus more than 30 beyond day 5. And you can see the ones who had developed complication, the platelet remained low, where the others who had a rise in platelet after day 5 had a good outcome as well. So just to summarize in terms of what happens. So if you got a hemodynamic stability, resolving ascites, decreasing lactate, resolving hypothermia, adequate urine output, improving mental status, bilirubin is going down, INR is coming down, good glucose metabolism. And if you still have got abnormal LFTs, then what to do? Sorry, all this has come in one go, but I tried my best. They should come one by one, but I think I just couldn't. So what you need to look at is whether the patient has got liver failure. So if they still have prolonged INR, they got encephalopathy, hypoglycemia, lactic acidosis, then you're dealing with something like PNF or a HAT or a non-thrombotic infarct or ischemic hepatitis. If they don't have liver failure and the enzyme pattern is predominantly hepatocellular and it is improving, then it is more likely ischemia reperfusion injury, so you sit tight and just wait for things to improve. If they are static or progressive, then again you need to anticipate they might have vascular issues. AMR is common. AMR is not uncommon in live donor liver transplant. I think AMR is common. Need to be careful there, and you need to make sure that you have given enough immunosuppression to this patient as well. Or they got ACR or subcapsular hematoma. Then if the enzyme pattern is mainly cholestatic, then if there is no liver failure, then it is resolving ischemia reperfusion injury or biliary or maybe drug-induced liver damage, which can happen especially you're giving multiple drugs, antibiotics, steroids, and tacrolimus as well. They can cause liver damage as well, and they can lead to transaminitis. If there is prolonged INR and HE, then in live donor liver transplant, you need to think about in the terms of small foci syndrome, sepsis, induced cholestasis, again very common, and there is an outflow problem. So all this actually, then again you do a vascular assessment. You need to make sure that all the anastomosis are doing well, and then you don't have a vascular problem. If there is no vascular problem, you do a liver biopsy. If there is a vascular issue anticipated, you do a CT angiography. If there is a biliary issue which is anticipated, then you do an MRCP to see whether they got a biliary problem. So in terms of graft dysfunction, so most people actually get confused that, patient who has got a HAT and has got transaminitis, high bilirubin. So that is not actually classified into graft dysfunction according to literature. Graft dysfunction, when we say, it is absence of treatable causes like vascular, biliary, or immunological causes. So if this is happening within 7 days, then it is termed as primary non-function or primary graft dysfunction. Then if it is happening beyond 7 days to 3 months, it is called as early allograft dysfunction or delayed primary non-function or delayed primary function. And if it is beyond 3 months, then it is called as late graft dysfunction. So again, this 3 months is arbitrary. There's no specific validation of all this, but this is what most literature or most papers will suggest. So when we come to PNF, PNF is basically, it's very uncommon in live donor liver transplant because these are healthy livers, the minimal cold ischemia time, but it happens in cadaveric setting about 1 to 2%. When it happens, it's a disaster because you can only save patient by retransplantation. So it is basically how you define is if you got AST level of more than 3000 anytime within 7 days of transplantation, then it is considered to be a PNF, and this patient should be relisted as well. If you got an INR of more than 2.5, you got persistent acidosis and lactate concentration of more than 4, then again this are considered to be patient is not doing well and they will need retransplant as well. So this happens, most PNF will actually manifest within 24-48 hours. It's unlikely they will go on for 7 days, because once you develop liver failure of this sort, they will actually deteriorate very rapidly. Then coming to early graft dysfunction, this is basically more common in live donor liver transplantation setting. So there have been quite a few definitions available in the literature, and there's a lot of controversy. So Althoff definition, which was derived from cadaveric data actually, it says bilirubin of more than 10 on day 7, INR of more than 1.6, and an AST-ALT level of more than 2000. So you don't really see AST-ALT level that high in live donor liver transplant. So we've done some work on this, and because the Althoff definition actually is very sensitive, but it is not very specific. So when we look at the literature, they will say around maybe 30%, 40% will satisfy the definition. But when we look at the outcome from that is the mortality related to early graft dysfunction, then this definition actually stands very poorly in predicting it. So what we did was we tried to develop a dynamic definition, which is based on if you have a persistent bilirubin of more than 10, INR of more than 1.6, and a urea of more than 100, for 5 consecutive days after 7 days of liver transplantation, then your probability of losing this patient goes up to 90%. And that is why it is needed. This definition is important because the decision in live donor liver transplantation about retransplantations are very difficult. You already done one live donor, and to ask family to have another live donor or to relist them is not an easy thing. It requires a lot of it will require, for another donor to be evaluated and have a transplant. These are not easy things for family and for the clinicians treating to decide. So you need a specific definition in terms of predicting mortality, and that's where our definition actually stands good. And I'm sure in coming days people will realize this is what it is. So urea is very important here. So it goes back to basics about how liver works and how urea, I'm not going to go into details of this, but I think this is an important marker of patient not doing well after transplantation. So I'll just take you through a few patients here. So this is just recently done transplant CLD. He had an autoimmune hepatitis B. He was on steroids as well. He had portal hypertension, and he had jaundice, encephalopathy, and he had a MELD score of 37. So he presented in October and went on to have a transplant in December. He had a very smooth operation. There was a problem with the portal vein initially, but it was it got reperfused well. And then this was his pattern of enzyme after the transplantation. So on day 1, he had a bilirubin of 18, AST of 2,500 here. And on day 8, the bilirubin is still staying high, and AST LT have come down to 163,391. And then he got extubated on the ICU as well. He had a good urine output coming as well, but you see his INR is still persisting with 3.6. So somebody would have thought this is just early graft dysfunction and or some vascular issue or something. But when we were looking at closely, his respiratory parameters were not very good at any time, and this is what he had in his lungs. So this is severe invasive fungal sepsis, which is leading to graft dysfunction as well. So liver absolutely fine, but because of respiratory sepsis, fungal sepsis, he has got high bilirubin and being unwell on the ICU as well. So this is just going to play. So this was just his contrast CT, just to show that the vascularity of the liver and intra-abdominal, there was as such no issue. So all the point here is everything, all deranged bilirubin, AST, ALTs and everything, they don't really mean directly in terms of that the graft is not doing well. Actually, this patient is holding there because there is a graft which is doing something good to him. And this all is happening because of extrahepatic problems. So he went on to have his bilirubin actually kept rising, and by day 36 it was 34, although his enzymes were still in 200s, and his INR is still holding at 1.74. So he needed trachea, he needed a lot of antifungals, so he was on M4 and fluconazole as well. And obviously because of prolonged ICU stay, he had myopathy as well, and but slowly he has made recovery. So again, now if you see his bilirubin has come down to 14, his AST/ALT still remains there, and his INR is 1.5. This guy is now able, he's feeding on his own, he's still on trachea, but his chest has improved, and we're just trying to mobilize him, and we will make home, I'm quite sure. So this is day 71 post-transplant. So the learning from this patient is, one is obviously not just graft, you can't just look at graft as one in isolation, you need to have a complete picture of the patient. And the second is, if you persist with patient, you will be able to send them. So you need to really put in a lot of efforts to make sure you don't get scared by that the bilirubin is 34, won't go home. You can't have those type of thoughts in yourself. You just have to persist with the patient, and at some stage they will turn around and go home as well. So this is just one example. We had lots of this type of patient who have made home after transplant as well. So coming to vascular issues, I'm sure most of you know there can be hepatic artery thrombosis, non-thrombotic still or spasm, it can be stenosis, it can be a pseudoaneurysm, or it can be an aneurysm rupture. So the most common is hepatic artery thrombosis, about 2 to 10%, and most of this will happen in early transplant period, and more common in pediatric. That's what literature say. Our experience have been a bit different, and the overall there is a decrease in the incidence, and again the definition of early and late is based on 3 months. So most of the time when we think about thrombotic vessels, we just want to point it to surgical. This one, it's not really surgical, it's just one aspect. So I just said technical is only one in the list, and there are lots of other reasons from which you can get a thrombotic vessel. So you just need to keep an open mind on all this. All this can cause a rejection, a CMV infection, drugs, even ABO-incompatible transplant, previous stay, all this can actually lead to vascular thrombosis. Technical is only one part of the equation. So the presentation can be asymptomatic, it can be biochemical with transaminitis. The thing is, if you have symptomatic presentation, then the outcomes are worse actually. So in terms of symptomatic, they may present with sepsis, recurrent cholangitis, or biliary problems like strictures, leaks, and abscesses, or they may have a full-blown graft failure. So early detection is very important, and either biochemical, ultrasound, and that's where the Doppler ultrasound, especially in the first weeks, are very important. We are grateful to radiology department. Shalini really doing good job in terms of getting those Dopplers done for us. And the sensitivity and specificity of picking up this actually ranges up to 70% as well. Whenever you are in doubt, just do a CT scan. And most of the time, actually, ultrasound will predict in terms of RI index and peak systolic velocity as well. So the management is revascularization. It can be surgical or endovascular, retransplant, or observation. And the best treatment option depends upon the timing and diagnosis. So I'm just going to take you through this paper. This is nearly 4,000 patients, and this is American data. HAT occurred in 5%, and obviously HAT versus no HAT, there was survival difference, gross survival difference as well. And a patient with HAT only had 10% graft salvage with anastomotic revision or thrombolysis. So why I'm highlighting this paper is when we look at our own data, so this is about nearly 650 patients, 21 had hepatic artery related complication. Out of this, 2.4 were thrombotic and 0.76 were non-thrombotic. The crux here is we detected at asymptomatic stage in 19 of these patients. So that's where actually only 2 of them actually were symptomatic because of hepatic artery thrombosis. And this is 18 of this happened within 7 days, and there was only 1 pediatric HAT at that time. So you can see there was no difference in transaminitis in between the HAT versus no HAT. They were detected on Dopplers, and we quickly actually intervened them, and we had a good salvage rate of nearly 80% here. So surgical revascularization was done in 7, which was successful in 3, unsuccessful in 4, and they had intervention radiological. 1 had portal vein arterialization, and he died. Then intervention radiology was done in 9 of this, successful in 3, unsuccessful in 6, and they went on, 3 of these actually went on to have surgery as well, and then 3 of them actually had further intervention procedure as well. Non-thrombotic complications can happen in terms of spasm, and if you do timely splenic artery ligation or you anticoagulate them, then they don't really need further intervention as well. So in non-thrombotic, all survived. 81% patient survival in HAT, which you see from the previous data, 10% there. And then overall mortality from heart related was about 3 out of 21. So that's about 14%. It was similar survival, although they had a higher biliary complication rate of 23% as well. So this is just to show a picture of intervention radiology. Amar, he always helps us. Nice way, they do it quickly as well, and how the liver was reperfused. So in this paper, the interesting thing was we were looking at what are the factors which can contribute. And what we've done over the time is we changed the way we do hepatic artery anastomosis. So this is the conventional way of doing it, where people will put bulldogs on both the side, and then they will do anterior wall, and then they will rotate the artery and then do the posterior wall. So what we've done is we don't do any rotations on the artery. We just go on in a clockwise suturing manner here, and that's how we complete the anastomosis. So this actually decreases the damage as well. The sutures are more precisely placed. There is minimal handling of the artery in this situation as well. And what we found was our technique was related to lesser complications of hepatic artery thrombosis. So whenever you have a suspicion of ARC, do Doppler, do conventional angiography. It will show us whether it is thrombotic, non-thrombotic. If it is HAT, within 5 days, surgery is the good thing to do. If it is more than 5 days, then intervention radiology. Okay. So again, portal vein thrombosis, coming to the complications are not that common. Portal vein thrombosis is about 2.6%. It is more common in kids because they have atretic portal vein and they have flow-related issues as well. Stenosis most commonly happen in longer term. That's because of the rotation of the graft, which is again more common in pediatric group as well. So the clinical presentation will depend on early or late. Early, then it will require immediate intervention in order to prevent graft loss. It is late, then it is more of an intervention radiological procedure. So I'm not going to go into details of this for the time's sake. Then, yeah, this is an important thing, and this is just to show you, this is spleen here, and these are the collaterals here. So when you're doing transplant, most of this patient will have collaterals and they will have shunt. And you need to make sure that you ligate all this shunt in order to get a good portal flow. So there have been a lot of belief in live donor liver transplantation that shunt can prevent hyperperfusion, but that's a wrong belief. I think you need a good portal pressure for liver to regenerate. And if you don't ligate this shunt, then there will be a low portal flow state and the liver won't grow properly as well. So you need to take care of this as well. So stenosis, when you have stenosis, again, it will present at transaminitis, some sort of, maybe they might have hyperbilirubinemia, and most of them will be get sorted with intervention radiology procedure as well. So outflow, this is very crux. I think this is the most important thing in live donor liver transplantation, because if you do a good outflow reconstruction, then whatever portal flow it is, the graft will accommodate. And but if you have an outflow problem, then again they are difficult to deal with, and most of this will present with some transaminitis, increased ascitic output as well. And so that's why if you don't have a good reconstruction, then you will get congestions on the graft, and then this will present as a small for size graft and the manifestations of graft dysfunctions as well. So we changed our technique on reconstruction as well. This has now become commonplace. I think most centers are now doing it. In terms of there were very few centers. I don't remember anybody using PTFE in India before we started using it. And now I believe most centers have come down to using synthetic graft for reconstruction of anterior septum. Then I don't think anybody was doing a single outflow before we started doing it and produced this paper, and I think most centers have now again come down to this as well. The important thing is this plastic actually prevents the collapse of right hepatic vein, and also you can do with a side clamp. So this is the cava here, and you can just put a side clamp here to do this anastomosis. So this is good for the anesthetist. The venous return is still maintained, and there is minimal hemodynamic instability during the reperfusion, because you still got venous outflow going into the right heart as well there. So we've shown that the middle vein patency is much better if we do a single outflow reconstruction, and in terms of overall outcome, it is much better in terms of morbidity and overall outcome, early graft dysfunction rate as well. So this is just to show the data from there. And in terms of if you have outflow problem, then again this will be managed by the intervention radiologist by stenting the veins in order to get a good venous outflow from the liver. So biliary, coming to biliary, is common, it still remains about 10%. Ours is also about 10%, but requiring intervention, it is about 5-6%. So it can be leak or it can be strictures. And most of this will be detected, the biomas will be detected on ultrasound. They will need further imaging in terms of CT scan and MRCP to see where exactly the leak is coming from, and then that's how you can decide. So this is just our own patient. He had a huge bioloma here. You can see this is the portal veins here. This is the dilated duct around here. So probably got an anastomotic leak. So the management will be to drain here first, and then try and see if we can get endobiliary stents into the ducts in order to seal those leaks as well. Sometimes they can be very difficult to deal with when they develop cholangiolar abscesses, and this can actually lead to graft loss as well. So these are tricky management, prolonged hospital stay, recurrent hospital stay. So the best thing is not to have them, just prevent as much as possible. So again, what happens is, when you start thinking biliary problem, surgical, anastomotic problems, and all those things comes into the mind, but this is not the case in all the cases. So this is again recently done, acute liver failure about a year ago. He satisfied King's College criteria, had a right lobe transplant, single anastomosis, ductal anastomosis, good outflow reconstruction as well. And this is about, he had persistent transaminitis remaining months after the transplant as well. So he had MRCPs done, and then you can see there he has got the strictures here. If you closely look at, this is the right duct which is here, and this is the common duct. So there is a ductal loss here, and this doesn't happen. Why you will get a ductal loss, and you start thinking what is happening here. And when we digged in, so this guy actually had persistent CMV in immediate post-transplant period for a very long time. He required 3 hospital admission to treat CMV with IV gencyclovir. So he's developed CMV-related biliary strictures. These are very difficult to treat and very difficult to deal with as well. So again, I'll just show his enzyme pattern here over the time. You see bilirubin was always actually normal, but he had transaminitis, rumbling transaminitis going on after the transplant, a month or 2 after transplant, and that was not resolving as well. And he has got rising SAP gamma GT there as well. And then if you see CMB levels here, we've got the CMB DNA levels here. So the persistent CMB DNA. Again, one of the things is, this is not very high logs, but still it is persisting. It's not gone away. So he probably got endobiliary CMB there, which can happen. And then once we did a biliary intervention, his enzymes did settle down, but the strictures will be difficult to deal with as well. Then the last bit, rejection. It's not that common in liver transplant as it is in kidney transplant, but it do happen. And so it's important to detect them early and treat them. I'm just going to take you this last case, how important to detect them early and treat. And there can be always with markers in terms of eosinophilia, which can reflect that patient is probably rejecting rather than sepsis, because sometimes it is very difficult to differentiate between sepsis and rejection. And if ultrasound again can show about Doppler, especially portal flows. So in rejection, the portal flow can decrease, and in severe MR, it will actually get reversed, or there won't be any portal flow as well. So it can be an early marker of detecting rejection, and the RI will also increase in rejections as well. So this is just a recent one. This is a CLD, autoimmune hepatitis, portal hypertension, young kid. He was lucky to get a liver from Bhubaneswar, and this is his enzyme pattern. So his bilirubin came down, and it was all doing well. His enzymes were coming down. Now you see on 28th it was 107. We were giving him TAC. His TAC levels were not building up in spite of him receiving around 2.5. So this is about 25 kilo boy who was receiving around 2.5 milligrams BD of TAC. He was receiving MMF as well and steroids as well. But if you see here, the enzymes are going up. Then suddenly on 29 there was a jump here, almost double. And this is where actually, this doesn't happen with sepsis or anything else. This is a rejection. And then we repeated the test after 6 hours as well, because we were suspicious that there is a sudden jump. Although vascularity of the graft was good, Dopplers were good, and then there was again doubling of the enzymes here. So we gave him bolus steroid on that night as well, 250. Then in the morning again we repeated 3 a.m. The tests were still going up. We still gave him 250 of methylpirate on that morning as well. And then again we repeated the test at 12 o'clock. Test is still going up. So we decided, and then 3 p.m. again going up, so we decided to give him 500 milligram of methylpirate, more of methylpirate as well. Again, test is still going up here, and it went up to 3,000. These are tests being done every 6 hours. So that's how that type of dynamic evaluation and testing and all has to be done. So at this stage, actually, at one time, we were thinking he's got AMR. And AMR is a very bad news actually. So we really got worried, and we were trying whether to do a plasmapheresis or this one. So we gave him one more dose. I thought we'll give one more dose and see how we go about it. And then we decided to give him ATG as well, because there was not much of rise here from 263, from 3,600 to 3,700. But I thought that he's not responding to steroid. We should give him ATG at this stage, and we gave him ATG. And then subsequently his TAC level also gradually got built up, and then his enzymes actually came down here, and they are smoothly coming down. Now TAC level suddenly shot up 13. So this is not because we've given him a lot of TAC. This is because he had graft dysfunction secondary to his rejection, and that's where the TAC metabolism comes into play. And the TAC level always, when you have, and it's a good marker actually, that you're giving TAC, and on low dose, if they're shooting up, that means there is something else going on. You need to be careful with those things. So that means they don't need immunosuppression actually. You should not be giving that. So again, TAC went up to 24 there. So we have tapered down the steroids, and his tests have now settled down, and his transaminitis is coming down as well. Okay. So this is the last slide probably. So this is, this is an interesting thing which we have done. This is part of EGLR score, and we try to compare the data from world literature to our own. So this is our data, 387 patient here, and when we look at US and Canada, 631 patient, the MELD score is 15 here, median MELD is 15 here, and you see the graft dysfunction rate was. So this is the EJD criteria, Althoff criteria, and the incidence of graft dysfunction they reported is 16 and 19%, and the graft loss is 24% there. Then when we just keep looking at it, this is one from China. So this is 260 patient, median MELD of 18. This is Japan actually, and same Althoff definition, 32% incidence of EJD, and a graft loss of 59%. Then there is data from India as well, and this is 135 patient, MELD score of 16, EJD score of rate of nearly 30%, and a graft loss of 4%. There's one more, I think. So when we come down to our own, so we got a MELD score of 24. In this actually it is almost 25. And we had an EJD rate of 33% and a graft loss of 9%. So that's where we stand in terms of what we've done in 1,000 transplant. This is as good as we can get in terms of what the world is doing and what we are doing. So management of patient post-transplant is intricate and very complex process, requires constant vigilance and a very dynamic approach. It is common for patient to develop issues, need to detect early at a stage where they just got inflammatory or SIRS, rather than developing dysfunction and failures. And you need to prevent organ dysfunction and failure. Graft function can be affected by multiple factors, so we should just not need to focus on liver. It is a holistic approach on the patient. You need to get the patient home. And clinical lab parameters are good. If you interpret them properly, if you have a dynamic assessment and you look them carefully, most of the time you will get an answer through this. And timely imaging is important to help decision making. Thank you very much. Thank you.